Hello, ladies and gentlemen. My name is Ana Maria Elena Kalin, and I'm a first-year resident at the Clinical Regional Emergency Hospital ILFO. Today, I'm gonna talk about the following case report: the results of a complex rehabilitation on a complete spinal cord patient. Spinal cord injury is a common diagnosis which appears into the rehabilitation clinics more frequently every year. The evolution of neurosurgical practices make more stable spinal cord injury patients and a larger addressability to the rehabilitation works. Every year around the world, between 250,000 and 500,000 of people suffer a spinal cord injury. Estimated annual global incidence is between 40 and 80 cases per million population. The majority of spinal cord injuries, like 90%, are due to the preventable causes. Spinal cord injury is a traumatic event that is debilitating and results in motor and sensory deficits below the site of the injury. Causes might be motor vehicle accidents in younger individuals, falls, people over 65 years old, acts of violence, and sport activities. More than 50% of the spinal cord injury occurs in persons with ages between 16 and 30 years old, most of whom are males, 80%. Males represent 90% of sports-related spinal cord injuries as well. My case report is a 37-year-old female patient that suffered an incomplete spinal cord injury and was admitted in the neurorehabilitation compartment at the Clinical Regional Emergency Hospital ILFO in January 2020, presenting distal paraplegic motor deficit, proximal and intermediate paretic deficit, anesthesia of both feet, reduced muscle strength, urinary and bowel incontinence, severe locomotor and self-care dysfunction. The personal medical history shows that the patient was involved in a traffic accident by falling off a wagon in September 2016, which caused an incomplete spinal cord injury. She undergo neurosurgery with metallic osteosynthesis at T12 vertebra. At the clinical examination at admission, the patient was afebrile, good general state, features and characteristic, and normal weight. Skin and mucous membranes, abrasions after burn injury on the lateral of the right calf, abrasions after trauma on the lateral of the left calf, bilateral abrasions and ulcers on the hallux and the fifth finger, infected sacral right bedsore. Adipose connective tissue was normally represented, superficial lymph node impassable and painless. Furthermore, the cardiovascular system showed normal heart sound with no added sounds or murmur, blood pressure 108 with 78 millimeters of mercury, and heart rate 78 beats per minute. Respiratory system showed bilateral equal air entry, normal vesicular breathing, and peripheral oxygen saturation was 99%. The osteoarticular system showed modified metatarsophalangeal joints bilateral, modified interphalangeal joints bilateral due to the crash syndrome caused by her own weight. The digestive system showed supple abdomen, pointlessly spontaneous and palpable, uncontrolled transit, lower limb of the liver at the costal margin, spleen cannot be palpated. The urogenital system, Giordano, was negative bilateral, uncontrolled urination. The neuromuscular arthrokinetic examination showed the patient was conscious, cooperative, temporally and spatially oriented, auto and physically oriented, cranial nerves within normal range, bilateral cutaneous hypoesthesia at L3, L4, and L5, bilateral cutaneous anesthesia as S1 and S2, bilateral incomplete paraplegia with proximal and intermediate motor control, bilateral complete dystoplegia, and cutaneous plantar reflex indifferent. The muscular strength, upper limbs are normal, lower limbs, proximal and intermediate motor control present the muscular force 4 out of 5, and dystoplegia muscular force 0 out of 5, and also bilateral clonus. Modified metatarsophalangeal and interphalangeal joints bilateral due to the crash syndrome caused by her own weight. Functional. She keeps resting in bed in decubitus dorsally, keeps position sitting on the edge of the bed. It is able to stand up with a walking frame. It is able to walk a few steps with standard walker and close supervision. The pattern of walking was altered. The lack of feeling in the lower limbs made the footstep without the plantar extension, thus having deformed toes and blisters throughout the skin of the feet. The patient has been clinically and functionally assessed according to the standardized protocols implemented in our clinic through the assessment scales: American Spinal Injury Association Impairment Scale, Functional Independence Measure, Quality of Life Flanagan supplemented by Barkhart, Ashworth and Penn, Functional Ambulation Category, and Walking Index for Spinal Cord Injury. Due to the American Injury Scale, the patient, after examination, presented hypoesthesia at L3, L4, and L5, and anesthesia at S1 and S2. And also, according to the Functional Independence Measure, the patient needs moderate assessment. Due to the laboratory examination, the patient suffers of iron deficiency anemia, and also the bedsore sampling for the bacteriology exam of the pressure ulcers identified Staphylococcus aureus. The radiology and cardiopulmonary erects showed a female 37 years old, the heart is not enlarged, the aorta appears normal, mild increased pulmonary vascularity in the infrahilar area throughout both lungs. Costophrenic angles are clear. Post-operative status after vertebra metallic fixation at lumbar level. The diagnosis shows paraplegia, American Injury Scale Frankel C after thoracolumbar spinal cord injury with T12 neurological level. Neurogenic bladder with urinary incontinence, neurogenic bowel with bowel incontinence, severe locomotor and self-care dysfunction, and mild iron deficiency anemia. The rehabilitation program that was used was electrotherapy, TENS, from sacral to feet, kinesiotherapy as well, and the results were improvement in walking, more control of continence by exercising the abdominal muscles, and also regain of feeling of light touch on the feet. A sacral right bedsore infected with Staphylococcus aureus was treated with specific antibiotic according to the bacteriology exam, and with specific patches was also used on alternating air pressure mattress. And the mild iron deficiency anemia, iron intravenous was used. After the 2 hospitalizations, the pandemic came and the hospital turned into COVID support, and the patient could not be admitted until present time. The follow-up on the patient showed that the bedsore gotten worse, larger, and plastic surgery was necessary, as you can see in the images below. In conclusion, paraplegia needs an extensive rehabilitation program for better results. Bedsore preventing measures should be repeatedly reassessed to have an appropriate treatment to facilitate faster healing. Rehabilitation on this patient, though, was extremely benefic, improving her general state, but discontinuity on the rehabilitation process and other medical evaluations because of the pandemic resulted in aggravated complications. The patient is expected to be readmitted in our clinic for further evaluation and to continue the rehabilitation program. Thank you so much for your time, and I hope you found my case interesting. Thank you so much for watching. Have a great day, everybody.